Hello. We'll try to explain what it means in English then. Please comment if you disagree with something that I say. I will start the presentation with a case story. And this is the case story that started my interest in the topic. I was on call, and it was a 52 years old male with no heart and lung diseases that was admitted to the hospital. He had infected wounds on both legs. He was dyspneic and he had fever. The same day he was admitted to the medical ICU, and I was called on to evaluate or to assess if he needed to be intubated. His circulation was unstable, blood pressure 70/40, he was tachycardic, he had high lactate, he had cold extremities, and he had already received 3 liters of normal saline and norepinephrine on 0.25 micrograms per kilogram per minute. His respiration was absolutely affected. The saturation on 84%, he was breathing fast, he was acidotic, and he was already put on non-invasive ventilation with a positive end expiratory pressure with 10 centimeters water. He already received 100% oxygen on the ventilatory support system. His infection blood tests showed the clear signs of infection, and of course, first of all, we have to stop and ask ourselves, what is the diagnosis for this patient? It's obvious that this patient is septic and he is in septic shock, and it's for me obvious that he needs to be intubated. He had been admitted to a medical ICU, and a cardiologist had already performed echocardiography. In the description, I could read that his left ventricle function was very good, and he had a very high ejection fraction, up to 80%. His right ventricle was dilated with reduced systolic function, and the systolic pressure in the pulmonary artery was moderately increased to 60 millimeter mercury. So when we see this, is it anything that will change our decision to intubate the patient? Well, when I read this kind of description, I have learned that it's important to look at the echocardiogram by myself, and the echo was looking like this. You see, the dilated right ventricle is extremely dilated, and the systolic function is absolutely decreased. The left ventricle is almost collapsing at every cycle, and it's very poorly filled. When we look at the description from the echocardiography one more time, we see that everything is correct, but it's about what the cardiologist is trying to emphasize. So we don't get afraid when we read that description, but when you look at the picture on the right there, we see that this is a very sick patient. But anyway, it's obvious that our patient needed to be intubated, and that was what I did. I intubated him, and he collapsed hemodynamically and respiratory even more. I had a really hard time to make him survive, and I tried everything, but the only thing that improved the situation was when I gave him fluid. So I gave him fluids, and the blood pressure increased, the norepinephrine doses could be reduced, his FiO2 was reduced, and because the oxygenation improved. So, but unfortunately, after I gave him fluid, the situation got worse again, and then I gave him more fluid, and then the situation improved, and this was repeated several times during that evening, and then suddenly the patient died. It was not surprising that this patient died actually, but my experience from that evening was when I asked some colleagues about support for how I should treat him, everyone was so insecure. I was very insecure because I knew that this was a dangerous situation, but every thing that I tried to do made me defensive because I was unsure if what I choose to do with the patient was doing harm. The only thing I saw that improved the situation was fluid. So when I asked colleagues about fluid, some said don't give fluid. Others said give a lot of fluid. And others were very insecure and couldn't give me any advice. So I decided I had to dig into this topic and learn this for myself. So today I'm going to talk about pulmonary hypertension in the critical ill patient. The first thing we have to keep in mind is ask yourself, what is dangerous? Why is it dangerous for us when we treat the patient with high pressure in the pulmonary circulation? I mean, we meet these kind of patients all the time. So the first one could be an 83-year-old male with COPD. He's going for laparoscopic surgery. The echocardiography is showing ejection fraction of 60%, and he could have systolic pressure in the pulmonary artery of 90 millimeter mercury. That is a severe increase in the pressure, and he has a dilated hypertrophic right ventricle. The next example is a young, healthy woman who recently been diagnosed with pulmonary embolism, and for any reason she needs surgery and she needs to be intubated. When we ask for echocardiography for this patient, she could also have ejection fraction on 60%. In this example, her pulmonary artery pressure are only moderately increased at 55 millimeter mercury, just like the patient that I started with, and her right ventricle is slightly dilated. Then we could meet a 68-year-old woman with a severe mitral regurgitation, and she gets dyspneic after walking 300 meters. Her ejection fraction is also 60%, and her pulmonary pressure is 70 millimeter mercury, and the echocardiography shows that the right ventricle are hypertrophic and dilated. All these patients has pulmonary hypertension. Should they be treated differently? And which of these patients are actually sickest? And which of these patients should we be most worried about? Then we have to know what is it very fair when we're starting to treat this patient, and maybe especially when we intubate this patient. The thing that we fear the most is that the cardiac output is decreasing, that the right ventricle is failing, and we fear that the patient will suffer from ischemic ventricles. But of these three reasons, the main reason that we should be concerned about is that the right ventricle will fail, because the high pressures in the pulmonary circulation is going to affect the right ventricle, and that's where we have to focus on our treatment to protect the right ventricle. When I start to dig into the literature, and I asked colleagues about where I could find good articles about pulmonary hypertension, all my colleagues are referring to this article. I mean, this is huge. It's more than 50 pages in European Heart Journal. It was published in 2016, and it's about diagnosing and treatment of pulmonary hypertension. So I was trying to look into this article to improve my knowledge about the topic. So when I looked at the table of contents, the first page, it was clear for me, well, nothing here is actually about the sick patient or the unstable patient. And in the next page, I can, well, here in the top left corner, it's intensive care unit management, page 94. Let's look at page 94. Balloon atrial septostomy, no, that's more, wait, here we are. Here we have advanced right ventricular failure and intensive care unit management. And we have a small slide here. And it's interesting, from more than 50 pages, this is everything that is mentioned about treating right ventricular failure in the intensive care unit. And I mean, almost 50% of the text here is about the French study that shows that 41% of the ICU patients with pulmonary hypertension dies, and they recommend that we should measure their heart rate, their blood pressure, and body temperature, and so on. And I mean, this is only obvious things, and it doesn't help me anything. What I find especially interesting to read about is they are saying that we should reduce the right ventricular afterload, which I agree with, but they say usually with parenteral prostacyclin analogs. And they have in the bottom right corner 3 references. What's interesting is in 2 of those references, they advise against giving parenteral prostacyclin analogs. So it was clear for me this didn't help me anything, and we should stop look at documents like this when we try to learn to treat patients that are critically ill with pulmonary hypertension. So I did a literature search by myself. I searched for pulmonary hypertension, right ventricular failure, and intensive care and critical care. I've found 6 review articles. You can say whatever you want about review articles. Yes, I know they're scientifically they're not worth much. It's only the author's opinion. Yes, I know, but this is all we got. One of the review articles, a review article, is actually a systematic review article, but it doesn't help us much. But what I did, I read these 6 articles, and I tried to put together how to understand the pulmonary hypertension in the critically ill patient. First of all, we have to be aware that the left ventricle is strong, and the left ventricle is getting a lot of attention. I mean, we know almost everything about the left ventricle, and we know how to treat immediate injuries and infarction, and we also know exactly how to avoid damage to the left ventricle for the next 50 years and so on. And we know so much about it, and it gets so much attention. But for me, the left ventricle is very strong, but it's not very smart. I mean, what is so impressive about the left ventricle? If the left ventricle receives small amounts of blood, it pumps out small amounts of blood. If it receives large amounts of blood, it pumps out large amounts of blood. And so this is not actually very impressive, but the forgotten part of the heart, the right ventricle, that's the brain. That's the one that regulates the cardiac output, because the right ventricle decides what the cardiac output would be, and if the right ventricle fails, the left ventricle will definitely fail too. But the right ventricle we know so little about, and this is kind of interesting, I think. Not gonna use a lot of time, but this is an impressive Norwegian family. It's the what is impressive that 3 of the children in these families actually are European champions in 800 meters running and 1500 meters running, and they are in the leading in a leading position in the world actually. And I mean, this is huge. And what is even more impressive is that it's their father that is responsible for the training process. I mean, this family is getting a lot of attention in the media in Norway. If one of them are getting the flu or something like that, it's been writing about for several days in the newspaper. And if one of them is injured by some way, the newspapers writes about it all the time. But all these 4 men wouldn't have had nothing if it wasn't for the one keeping the family running, making sure their laundry is done, making sure everything, the practical things are going okay. And that's her, the mom. But she doesn't get as much as attention as the other guys. So today's lecture is actually about to honor the hardworking people that's forgotten in the big picture. So the left ventricle is working in a high pressure system and it's meeting high resistance. A normal blood pressure for the left ventricle to produce is 120/80, but I mean, systolic pressures I have seen way over 300 millimeter mercury, and the left ventricle is coping quite well with that. It's not a problem. It's not healthy for the left ventricle, but it's able to produce high pressures. The problem is producing these high pressures demands a high oxygen consumption. And why? The reason the pressure are so high is like the concrete building. We see the lady at the top floor. She is, when she needs water, it's very important that the pressure in the pipe system is high enough. So that's when she opens up, she needs high enough pressure so that she can receive water. If the pressure isn't high enough, then it doesn't help if she opens up her pipe, because then no water will come into her apartment. It's the same in the arterial system. We need to have a high pressure in our arterial system, because when we are trying to run away from some dangerous things, our thighs are needing a lot of oxygen, so they will become acidotic, and that will give a regional, a local dilatation of the arterioles in this area. And because of the high pressure in the arterial system, the blood flow to these areas will increase, and by then it will increase their ability to get more oxygen. The right ventricle is working in a low pressure system and it meets low resistance. The pressure that the right ventricle is producing is normally 20 millimeter mercury systolic, and it's very seldom it's produced a higher pressure than that. The positive thing about that is that this way it decreases the oxygen demand. And I mean, this is pretty smart, because the only thing the right ventricle is supposed to do is to pump blood through the lungs over to the left ventricle. It's not about the ability to redistribute blood like we need in the systemic circulation. So this is a smart way, and it saves the right ventricle for oxygen demand. So this is smart. When the right ventricle pumps blood through the pulmonary circulation, the pressures are so low so that more blood goes to the bottom or the dependent part of the lungs compared with the higher regions. In this example, the right ventricle is pumping 4 liters per minute, and that would be the same amount of blood that the left ventricle would produce in the same situation. But the vessels in the pulmonary circulation is very compliant, and even though the right ventricle produces the same cardiac output, the resistance is so low, so the systolic pulmonary artery pressure is only at 20 millimeter mercury. But sometimes we need even a higher cardiac output. So what happens if we increase the cardiac output by 50%, and in this example 6 liters per minute? When the cardiac output increases, the amount of blood is also increasing. But what is happening when this increased blood flow is going through the lungs? Because of the high compliant vessels, they will easily expand, so that the same or the increased amount of blood will go through the lung circulation, but still it will only the right ventricle only needs to produce 20 millimeter of mercury, exactly as the last example. This is the most important part of understanding how to treat pulmonary hypertension and how to avoid a dangerous situation, and it's about perfusion of the right ventricle through and how the blood flow varies or being affected in the right coronary artery. The right coronary artery is perfusing the right ventricle and parts of the septum, and it comes from the aortic root, and it's flow dependent, and it depends, the flow depends on the pressure gradient between the aortic root and the wall tension in the right ventricle heart wall. When the pressure is high in the aortic root, the blood flow is depending on what kind of pressures there is in the heart wall and the wall tension it produces. I mean, there is no pump or something that pumps blood from the aorta and over to perfuse the heart wall. It's only about pressure gradients. And that means we need to keep the pressure high in the aortic root area, and we need to keep the wall tension as low as possible to facilitate or make the blood flow in the right coronary heart as good as possible. If the wall tension increases, then the pressure gradient will be smaller, and the perfusion of the heart wall would decrease. So why is the wall tension in the heart varying? Then we know we have to go back to the law of Laplace. He said that the wall tension is being increased by the pressure inside a bubble, but to be precise, it's actually about the transmural pressure. So it's dependent of what the pressure is inside the bubble or inside the right ventricle, and also outside the bubble or the right ventricle. This is actually very important because the heart is within the thoracic area, and the pressure inside or the intrathoracic pressures are varying throughout the respiratory cycle. So When the pressure increases, the wall tension increases, but it's also important to see that when the radius is increasing, then the wall tension increases as well, and the right ventricle, when the right ventricle suddenly meets higher resistance, it will dilate, and only the dilation of the right ventricle is producing a higher wall tension. If the wall thickness is increasing, we can see from the equation that the wall tension will go down. Both the radius and the wall thickness is done in centimeters and can be taken away. So we see that the wall tension is measured as a pressure. So that means the wall tension by itself is producing a pressure within the wall. This is what we have to keep as low as possible when we're dealing with these patients, because a higher wall tension will decrease the pressure gradient with the aortic pressure. The other part that's dependent for the pressure gradient is the pressure in the aortic root, and that is, as we know, the systemic blood pressure. Therefore, it's very important when treating this patient is to keep the systemic blood pressure high enough to keep the coronary perfusion optimal, because we believe that hyperperfusion of the heart is a major reason for why the right ventricle is collapsing. We remember these figures from medical school. The blue line is the pressure in the aortic root, and the red line is showing the pressures inside the left ventricle. When the aortic wall is opening, we see that the pressures are almost the same in the aorta as it is in the left ventricle. But when the aortic valve is closing, the pressure in the aorta is maintained throughout the diastole. Inside the left ventricle, the active relaxation is setting in, and it decreases the pressure actively and very effectively. The pressure inside the left ventricle is a major part of the result of the wall tension, and we then see that there is a gradient between the pressures in the left ventricle and the aorta in the diastole, and this is why we know that the left ventricle is only getting coronary perfusion during diastole. In the systolic period, the pressure gradient is close to zero, and the left ventricle doesn't get any perfusion. It's different for the right ventricle, because the right ventricle is operating in a low pressure system. So the pressure in the right ventricle will, under normal conditions, stay low throughout the cardiac cycle. This means the pressure gradient between the aortic root, or the pressure in the blue line, and the pressures that's producing the wall tension in the right ventricle is remaining high throughout the cardiac cycle. So the right ventricle receives coronary perfusion also in systole, and as it does in diastole. When the resistance increases throughout the pulmonary circulation, the right ventricle has to increase the pressure it produces to overcome that resistance. That means the pressure in the right ventricle increases. And when the pressure increases, the oxygen consumption increases as well. But as we see, the pressure gradient is becoming less. So that means as the pressure in the pulmonary circulation increases because of the high resistance, the oxygen consumption increases, but the oxygen demand decreases. And this is something we have to do everything to avoid. When the pressure increases even more, well, we know what happens with this patient. When the right ventricle is pumping blood throughout the pulmonary circulation, it's easy to see that when something happens within the pulmonary circulation, it will immediately affect the right ventricle. And we have to remember the right ventricle is thin-walled and it's not able to produce high pressures. So what happens within the lungs is affecting the right ventricle. As we remember, when the left ventricle meets high resistance, as it always does, it's coping with that situation pretty well. The right ventricle, by the way, only when the resistance is increased slightly, it's starting to struggle. And when the resistance is even higher, it's very easy for the right ventricle to give up, and then the patient will experience a cardiac arrest. The pulmonary vascular resistance is being affected by several factors. One of them is the pulmonary hypoxic vasoconstriction. When the partial pressure of oxygen within the alveoli is low, this is a situation we can have with atelectasis, with pneumonia, with edema, and other reasons. This reflex is being made so that the blood vessel going to these areas will constrict. That means the resistance in this area of the lung will increase so that it redistributes blood to the ventilated areas of the lungs. But if it's large areas with hypoxic vasoconstriction, then the resistance will increase in total in the lungs, and that could affect the right ventricle. So it's an important thing to keep the parts of the lung open and as ventilated and oxygenated as possible. Normally this is a very good reflex because it reduces the shunt fraction in the lungs. A smaller part of this vasoconstriction is when the oxygen level or the partial pressures of oxygen inside the blood is low. That is hypoxemia. And when the partial pressure is low in the blood, then we will have a more general vasoconstriction. So hypoxemia also produces increased pulmonary vascular resistance that could affect the right ventricle. When the right ventricle is pumping blood through the pulmonary circulation, the blood leaves the right ventricle and goes into the pulmonary artery. The respiratory variation throughout the respiratory cycle will vary the resistance that the right ventricle has to overcome. And it's particularly two places in the pulmonary circulation that affects this resistance. The first area is in the precapillary arterioles. The second place where it's mainly affected, it's the circulation through the alveolus in their capillaries. So these two areas affects the pulmonary vascular resistance. Of course, when we are breathing spontaneously, the pressure inside the thorax is varying throughout the respiratory cycle. During inflation, the intrathoracic pressure decreases. The decreased intrathoracic pressures leads to less pushing to the alveoli, so the alveoli will expand. This is how normal respiration is happening, so it's not a very big deal and it shouldn't be surprising to all of you. But of course, the decreased intrathoracic pressure doesn't only affect the alveoli. It also reduces the outside pressure in the precapillary alveoli. So the precapillary arterioles will expand because the transmural pressure in this area will increase. An increased radius in this area will decrease the resistance. During expiration, the intrathoracic pressure increases, and because of the increased intrathoracic pressure, the alveoli will be pushed to a smaller radius, and this is how expiration happens. But the increased intrathoracic pressure will also decrease the transmural pressure in the precapillary arterioles, and this will increase their resistance in this area. We have to look more specific into this. When the patient is putting on positive pressure ventilation, it isn't the pressure in the thorax that is the starting point. On the ventilator, we push pressure inside the alveoli, so the situation is different. During inflation, we increase the alveolar pressure so that the alveoli will expand. This will lead to an increased pressure inside the thorax, and this increased pressure will again decrease the transmural pressure in the precapillary arterioles. So all this will affect the total PVR during the respiratory cycle. And on the right side of this slide, we have on the top the PVR, or the pulmonary vascular resistance, how it varies in spontaneous ventilation as the lung volume increases on the x-axis. During spontaneous ventilation, the intrathoracic pressure is decreasing the more volume the lung is receiving. It's opposite during mechanical ventilation. As the lung volume increases on the x-axis, the intrathoracic pressure is also increased. It's quite the opposite from spontaneous ventilation. Well, we then have to look at how does the pulmonary vascular resistance being affected by the respiration, both in spontaneous and mechanical ventilated patient. First, we're going to look at what happens when the blood flow passes the alveolar capillaries. As the inspiration is going on, the lung volume is increasing and the alveolus the radius is getting bigger. The capillaries that surrounding the alveolus will then be so that the length is increasing and the radius is being decreased. This is producing a higher resistance because of the increased length and reduced radius. So that means the larger the alveoli are, the larger the lung volumes are, the more resistance the blood flow has to overcome. So in the figures on the right side, that means that in both spontaneous ventilation and mechanical ventilation, the resistance will increase as the lung volume increases. But the resistance is also being affected in the precapillary arterioles. So what happens there? Here we have to differ between the spontaneous ventilation and the mechanical ventilation. During spontaneous ventilation, we know that the intrathoracic pressure is decreasing as the lung volume increases. The decreased intrathoracic pressure is making the outside pressure from the arterioles less, so that the precapillary arterioles will increase their radius. That is why, as the lung volume increases, the intrathoracic pressure decreases more, and the contribution from the pulmonary vascular resistance from the precapillary arterioles will decrease as the lung volume increases. The total PVR is decided by the sum of all the resistance the flow encounter throughout the pulmonary circulation. That means first we have to look at the contribution from the alveoli circulation, and then the resistance from the precapillary arterioles. When we add those two together, we get the famous U-shaped curve that was has been with us from 1950. Guyton started this, and he claimed that the lowest PVR was at FRC, and that with increased or decreased lung volumes from FRC, the total pulmonary vascular resistance would increase. The problem is I have seen this figure in a lot of articles and at a lot of lectures, and this U-shaped curve has been referred to also in mechanical ventilation. This is my proposition that this can't be correct. We cannot use this understanding when we are doing positive pressure ventilation with the patient, because when during inflation in mechanical ventilation, we explained earlier that the intrathoracic pressure is increasing. The increased thoracic pressure would push extra on the precapillary arterioles so that the radius is decreasing. That means during inspiration and during increasing pulmonary lung volumes, the part or the contribution from the precapillary resistance is not decreasing as we explained in spontaneous ventilation. It must be the opposite. The contribution on the resistance is increasing as the lung volume increases. And in this situation, when the lung volume is increasing, we see that both the contribution from the alveoli capillaries and from the precapillary arterioles are increasing, and we still have to add those contributions so that the total PVR will have a steeper rise. It will be almost exponential. And one other interesting part is the curve loses its U shape. That means the lower the lung volume is, the lower the pulmonary vascular resistance becomes. But of course, at some point, when the lung volume is low enough, we will start producing atelectasis. So, from my understanding, the lowest PVR must be at the closing capacity volume. One other interesting part of this understanding is that when we intubate this patient, it's not only that the PVR is increasing and that the right ventricle has to overcome that increased resistance as it is in spontaneous ventilation, but in mechanical ventilation, the increased lung volume increases the resistance exponentially. So it makes it extra dangerous to intubate these patients. But of course, sometimes we have to do it. So, but then we have to know that this is a very risky procedure to perform. In my opinion, echocardiography is the best way to follow the hemodynamics in a patient with a threatened systolic function for the right ventricle. But it's important to do it together with knowledge about how the resistance is affecting the right ventricle systolic function. With a PICO catheter or PICO catheter, A low cardiac output could either be because the left ventricle is failing, or it could be because the right ventricle is failing, and we don't know which of them is having the problem. It's with the pulmonary artery pressure, now the pulmonary artery catheter, you can measure the pressures in the pulmonary artery and the cardiac output, but and it's a very useful tool to assess this group of patients. But the problem is you can't see dilatation. And as we showed in the equation from Laplace, dilatation or increased radius is one major issue to control. And when the right ventricle is facing increased resistance throughout the pulmonary circulation, the first thing it does is to dilate. So dilation of the right ventricle is an extremely important information. So I encourage you all, learn to perform echocardiography and start now. With echocardiography, we will assess the dilatation and the systolic function of the right ventricle. Normally, the right ventricle should be only 2/3 of the left ventricle, and we say it is moderately dilated if it's between 2/3 and 1. When the right ventricle is bigger than the left ventricle, it's a severe dilatation. But what is very important, even small dilatation is a serious warning sign that something is about to threaten the right ventricle. So when someone is describing an echocardiography and they only write slightly dilated, then don't be relaxed. Be careful about that situation. The systolic function is a great way to assess it is by doing it visually. You can see that the right ventricle is pumping effective, and it's actually a good tool to assess it. To get a number on it, you can measure the TAPSE, and if TAPSE is low, then it could mean that the right ventricle is failing. TAPSE is measured by the M mode, where the M mode is put in the AV plane on the lateral side, and we measure how many centimeters the AV plane is moving towards the apex. If the movement is below 1.6 centimeters, then we probably is facing a right ventricular failure. We are also able to measure the pressure inside the pulmonary artery if we have a tricuspid regurgitation at the same time. During systole, with an open pulmonary valve, the pressure in the right ventricle is equal to the pressure in the pulmonary artery. So when we have a tricuspid regurgitation, we can see the green and the blue line going from the ventricle to the atrium. Then the bigger the pressure gradient between the ventricle and the atrium is, the faster the blood flow, the velocity will be. So we measure this pressure gradient with Bernoulli's simplified equation, which say that 4 times the velocity squared is the difference in the pressure in the 2 chambers. So to evaluate this, we put the continuous wave Doppler inside the regurgitation, and then we measure the velocities. And with help from Bernoulli's simplified equation, we can measure the pressure inside the pulmonary artery when we add the pressure in the right atrium as well. So, but the pressures measured alone isn't that important. The absolute pressures doesn't say that much, because as you remember the 3 examples in the start of the lecture, the 23-year-old woman with pulmonary embolism, she only had 55 millimeter mercury in the pulmonary artery. The patient in the case story had 60 millimeter mercury. And unfortunately, we are using the definition from primary arterial pulmonary hypertension as if the pressure are elevated in moderately or severely and so on. This is a totally other situation, because when you do have a healthy right ventricle, it has never increased met increased pulmonary vascular resistance. So when at for instance at ARDS or at pulmonary embolism, the pressure, the resistance is suddenly increased, and then the right ventricle isn't able to produce high pressure to overcome the increased resistance. So that a healthy right ventricle is only able to produce about 60 millimeter mercury. If the right ventricle needs to produce more or a higher pressure to overcome the increased resistance, then it will fail. And then the cardiac output will go down, and the systemic cardiac output will go down, and we are in a serious situation. So when we see a 60 millimeter mercury measure in the pulmonary artery, we should be really concerned, because if we have a chronic elevated pulmonary hypertension, then the right ventricle will hypertroph and be thicker, so that it's able to produce higher pressures. And I mean, this chronically increased pressures in the pulmonary circulation it has been adapted by the right ventricle, who has been stronger. So it's, in my opinion, less dangerous to put a patient with a chronic disease on the ventilator compared with the healthy ones. So the young, healthy persons are the most dangerous to put on positive ventilation, especially when their systolic pressure are around 60 millimeter mercury. But dilatation of the right ventricle is always a severe situation. When the pressure in the right ventricle is increasing even more, the higher pressure will push the septum inwards to the left ventricle, and that will produce the popular D sign phenomenon. It happens first in the end systole, actually, because the systole is lasting longer for the right ventricle compared with the left ventricle. The displaced septum will make it more difficult to fill the left ventricle, and it will make the diastolic properties worse, so that this underfilled left ventricle will need higher filling pressures to receive adequate stroke volumes. And the displaced septum will also affect the systolic function, because the way it is pushed into the left ventricle, it will affect the systolic properties as well. So, to protect the right ventricle from failing when it's facing increased resistance, we need to put up a defense like the white chess player is doing in this situation. The way we are protecting the right ventricle is by keeping the pulmonary vascular resistance as low as possible. To maintain an adequate gradient to facilitate coronary perfusion, we need to keep the systemic vascular resistance as high as possible. When dealing with these issues, we are talking about the PVR-SVR ratio. That means when some medicines are affecting both the PVR and the SVR, it is important that it affects differently. So when the PVR-SVR ratio is increasing, it's not good. If the PVR-SVR ratio is decreasing, it's a good sign that we are protecting the right ventricle. So what we need to do is keep SVR high and keep PVR as low as possible. When we put the patient on mechanical ventilation, we know that we increase the intrathoracic pressure. That will increase the afterload for the right ventricle, so the PVR is increasing. At the same time, the afterload for the left ventricle is decreasing. So this procedure is doing the situation worse for the patient. So what we have to do is to keep the tidal volume as low as possible. As you remember, the exponential growth in the increased resistance when we put the patient on positive ventilation can be dangerous potentially. But we need maybe high enough tidal volume so that we can exclude hypercapnia, because hypercapnia may also produce higher PVR. We need to increase the expiration time, because that's the period where the pressures in the thoracic area is lowest. And the PEEP, increased PEEP will increase the PVR. The increased intrathoracic pressure will increase PVR, but also the dilation of the alveolus will make an increased resistance. From studies, especially on ARDS patients, they have seen that PEEP values up to 10 centimeters of water is probably okay. And my theory is that as long as PEEP is opening up at ectasis, it is probably reducing PVR. But when PEEP is increased higher than when we have reached the closing capacity, it is probably increasing the PVR. So the take-home message for this is that when you have the unstable patient, it's probably okay to increase the PEEP up to 10 centimeters of water. General advice is plateau pressure below 30 centimeters of water. Some suggest 27 centimeters of water, and driving pressures under 20 centimeters of water, and some suggest under 18. But of course, a driving pressure up to 20, we should always try to keep it as low as possible, because it will also decrease the PVR. During induction, we have to remember that we need to use hemodynamically stable medicines, so we have to avoid propofol, thiopental, and medicines that decreases the SVR. We have to keep the pressure in the systemic circulation as high as possible, because we know that this will fall when or decrease when we start the ventilation, and because of the medicines we give, and that will affect the gradient between the aortic pressure and the wall tension. So we advise using ketamine. Ketamine is in some places discouraged to use in pulmonary hypertension because of the potential increase in pulmonary vascular resistance, but most of the articles I have read, they have good experience using ketamine, so I advise using ketamine. Of course, you can use fentanyl, midazolam, whatever you want. Before induction, I always try to insert a central line so that we can start vasopressors. I choose norepinephrine, and I choose to start the infusion even though the blood pressure isn't low, because it's important that the central line is completely filled with norepinephrine. Then we have to avoid hypoxia and acidosis, that both will increase PVR. So I advise to ventilate during the apneic phase. So the big question is about fluid. The problem, when you look at the large right ventricle, you can see it is overfilled. When you look at the compressed left ventricle, it is poorly filled. The problem is that when we are measuring the PVV or SVV, they are always very positive. When we do an leg raising, it will be positive, and the reason is the left ventricle is screaming for more pressure. So when we are giving more fluid into the right ventricle, some of this fluid will be increased over to the left ventricle. The problem is, for every drop of fluid we are giving this patient, the right ventricle will dilate even more, increasing the wall tension and decreasing coronary perfusion. So my advice is you should not give fluid to this patient even though they respond positive. In the beginning of the lecture, I told you about the case story in my situation. I chose to give fluid to that patient. Today, I know it wasn't smart. Probably I was pushing the patient over to cardiac arrest because I gave fluid, because I trusted my clinical experience when I saw that the situation got better. You should give diuretics if it's possible, but many of these patients are so unstable that it is difficult to give diuretics. But if it's possible, start as fast as possible. If the patient is bleeding, give blood, of course. If it's severe hypovolemia, of course, you must give fluid. But if there is severe hypovolemia, the right ventricle will not look like that. This is in contrast to our experience when we have right ventricular infarction and tamponade, because then we should give a lot of fluid. And why is that so? The reason is it's the systolic pump function that is affected. It is not increased PVR that is the problem. So when we are giving fluid to the systolic ventricular failure with a low PVR, as in the infarction, we give a lot of fluids to increase CVP, so that the increased CVP will work closely as a fontaine circulation, so that some fluid will pass through the pulmonary circulation and fill the left ventricle. It is only as a bridge for survival towards PCI or coronary artery bypass surgery that can save the patient. But in the increased PVR, don't give fluid. In the case story I started this lecture with, I was very uncertain if everything I did was affecting the PVR. I was afraid of giving propofol, I was afraid of giving norepinephrine, I was afraid of giving everything because I didn't know how it would affect the PVR. Now I'm going to go through some of the important medicines and try to explain why they are advised to use or why they are recommended not to be used. Of course, there's very weak scientific evidence, and a lot of them are based on animal experiments and physiological understanding, but there are some human scientific experiences as well. But we know very little, but this is what we know. We want the medicine that we give to increase contractility both for the left and the right ventricle without increased oxygen consumption. We want to decrease the PVR and sustain the SVR. We want to avoid tachycardia, and we want to avoid arrhythmias, and we want to, of course, improve the ratio between PVR and SVR. Unfortunately, this medicine doesn't exist. If this medicine did exist, it would decrease PVR, it would increase SVR, it would increase right ventricular contractility, it would increase cardiac output, and it would decrease the PVR-SVR ratio. As the figure we remember from earlier, we can take away the left ventricular pressures. So what we want is to decrease the PVR, and we want to increase the SVR to facilitate a bigger gradient so that it is easier for so we will have a better coronary perfusion. So phenylephrine. What is happening when we're giving phenylephrine? Should we give phenylephrine? Well, one of the main effects of phenylephrine is of course to increase systemic vascular resistance. If this was the only effect, it would increase coronary perfusion, and we would advise the use of this medicine. Unfortunately, the PVR is also increasing, so that we believe that the gradient between the systemic pressure and the wall tension in the right ventricle is decreasing. It is therefore advised not to use phenylephrine. But I have to mention some of the articles said they had good experience using phenylephrine, so this is a difficult question we don't know the exact answer to. But I advise stay away from phenylephrine. We do have other medicine to take care of that. So what about noradrenaline or norepinephrine? Of course, the SVR is increasing. That's why we're using this vasopressor. And but we have to know how it affects the PVR as well. Well, it seems like up to 0.5 micrograms per kilogram per minute, the effect on PVR are very low or none. In doses above 0.5, it may increase PVR. Therefore, we advise to keep the SVR high enough. We want the first line pressor to be used should be norepinephrine, and it could be used up to doses on 0.5 mics per kilo per minute. It may also have a positive effect on the cardiac output by the beta stimulation. Vasopressin, how does it work? Well, of course, it increases the SVR, but does it affect the PVR? Well, some authors claims that it actually decreases PVR, but I believe that is only because we put the numbers into equations. Probably it's unchanged, and probably there are no vasopressin receptors in the pulmonary circulation. So it has a very good profile protecting threatened right ventricles. So we advise even earlier than what we're used to start vasopressin to reduce the amount of norepinephrine. We advise using 0.02 or 0.04 units per minute, and we started early. Of course, it has a long half time, so it's not suitable medicine to go up and down if the pressure changes, but it should be just going, and we should increase or decrease the norepinephrine if necessary. Dobutamine is increasing right ventricular contractility and cardiac output. It is decreasing the SVR, so that's something we don't want, but it's also decreasing the PVR. So we don't know how the PVR-SVR ratio is affected, but in the literature it is advised to use dobutamine up to 5 mics per kilo per minute. I am a little skeptic about this, because the increased right ventricular contractility, possibility of an increased afterload would be that the coronary perfusion will decrease even more. So I think it's a little bit risky, but the literature is advising using low doses of dobutamine. But to stop the fall in SVR, it should be used together with another vasopressor. Doses above 5 mics per kilo per minute is probably not good, and because of the increased oxygen consumption from the heart and the increased incidence of arrhythmias and the tachycardia. Epinephrine, it's very strange. There is almost none evidence regarding this medicine. So some advise starting early, some advise not use it. I'm not sure. I think epinephrine is a very uncertain medicine, but I use it when I'm standing there and don't know what to do at all. And of course, Inhaled nitric oxide will just have an effect in the pulmonary circulation, decreasing the PVR, so that it's a very or potentially very effective medicine to improve the PVR-SVR ratio. Unfortunately, we haven't had the scientific proof that it saves life, but we use inhaled nitric oxide. Thank you. That was what I was about to say. If you have any comments, I would be happy to start a discussion. Thank you.